Hello, my name is Jonathan Levin, and I am an instructor of pediatrics at Harvard Medical School and attending neonatologist and pediatric pulmonologist at Boston Children's Hospital. Today I'll be discussing our article, Pre-Flight Hypoxemia Challenge Testing in Bronchopulmonary Dysplasia. Preterm infants are at risk of developing hypoxemia during air travel, with greatest risk seen in those with bronchopulmonary dysplasia. Cabin pressurization during commercial flights results in an oxygen tension that is equivalent to breathing a fraction of an inspired oxygen of 15% rather than 21% at sea level.
Many families are eager to travel with former preterm infants but are unsure when it is safe to fly. High-altitude simulation testing can identify infants at highest risk for in-flight hypoxemia and who may require supplemental oxygen for safe air travel. As seen here, this is done by administration of 15% oxygen blended with 85% nitrogen via a face mask and monitoring pulse oximetry throughout. Few guidelines and studies exist when this testing is indicated. British Thoracic Society guidelines suggest that infants under 1 year of age with a history of neonatal chronic lung disease should have high-altitude simulation testing performed, though other studies suggest that those infants with BPD may still develop hypoxemia during air travel beyond a year of age.
In this study, we analyzed high-altitude simulation testing done in former preterm infants with BPD at Boston Children's Hospital over an 8-year period. We conducted a survival analysis with interval censoring to estimate the time to event curves of the first pass. We then stratified curves by neonatal risk factors to determine which risk factors put infants at risk of developing hypoxemia during high-altitude simulation testing.
We analyzed 94 studies from 63 patients with BPD. 59, or 63% of studies were passed. At 3 months corrected age, 50% of subjects had passed. At 6 months corrected age, 67% had passed. At 12 and 18 months corrected age, 72% had passed. And at 24 months of age, 85% had passed. Neonatal factors associated with delayed time to pass included receiving postnatal corticosteroids, requiring respiratory support at NICU discharge, and need for tracheostomy. At 24 months corrected, children with a history of pulmonary hypertension had only a 63% chance of passing, and those discharged from the NICU with oxygen or on respiratory support had a 71% chance of passing. On the other hand, infants with BPD who did not require respiratory support at 36 weeks had a greater than 90% chance of passing as soon as 6 months corrected age. Similar results were true using a Cox proportional hazard model controlling for gestational age, birth weight, and sex.
Based on this, we propose that clinicians should consider performing pre-flight hypoxemia challenge testing through 24 months of age in children with BPD who remained on respiratory support at 36 weeks post-menstrual age. On the other hand, infants who did not require respiratory support at 36 weeks post-menstrual age may not require testing after 6 months corrected age. Infants who develop pulmonary hypertension and those that were discharged from the NICU on respiratory support may develop hypoxemia during the challenge beyond 24 months. This has important implications for neonatologists, pediatricians, pediatric pulmonologists, and pediatric cardiologists on how they counsel families of former preterm infants on the safety of air travel. Thank you.